Okay, thank you very much for the invitation. Could I have my presentation, please? Thank you. So thank you very much for the invitation, which gives me the opportunity and the great pleasure to talk to you about prosthesis patients mismatch. So aortic stenosis is the most common valvular heart disease in Western countries, and despite improving prosthesis, we still do not have the ideal prosthesis. So the rationale for development of new bioprosthesis, like here the trifecta, I wanted to emphasize the fact that there is a supraannular implantation, and the leaflet, 3-leaflet pericardial shield is mounted externally on a titanium stent and a small sewing ring. So the rationale for using bioprosthesis is that they are low thrombogenicity, which doesn't require ND anticoagulation therapy. However, there are several issues remaining, like the structural deterioration, sometimes challenging implantation, and most importantly, hemodynamic performance. So prosthesis patients mismatch PPM. So when does it happen? Well, it occurs when the effective orifice area of a normally functioning aortic prosthesis is too small in relation to a patient's body size, to patient's cardiac output requirements, resulting in a high transvalvular pressure gradient through a normally functioning valve. And in the aortic position, it is considered as moderate when the indexed effective orifice area is less than 0.85 centimeters square per meter square, and severe when indexed effective orifice area is less than 0.65 centimeters square per meter square. Its prevalence ranges from 20 to 70% for moderate PPM and 2 to 15% for severe PPM, and it is strongly associated with smaller size valves. So you have here the relationship between mean systolic gradient and aortic valve area. And the mean systolic gradient remains constant until the aortic valve area is decreased by 50%, and then it increases gradually until 65%, and afterwards it increases markedly. Here is another representation, the curvilinear relationship between mean gradient at rest and indexed effective orifice area at rest. So what are the consequences of PPM? Well, it has been shown that PPM was associated with incomplete regression of left ventricular hypertrophy, and the biggest increases between the aortic valve area before the surgery and the indexed effective orifice area after the surgery. Well, the biggest, it increases, the higher is the regression of left ventricular hypertrophy. What about on the outcome? It has been shown, even if there are some discrepancies in the literature, that patients with basically PPM have a lower overall and cardiovascular survival, and patients with severe PPM has a lower survival when they are compared to patients with moderate PPM, and patients with moderate PPM have a lower survival when they are compared to patients with no PPM. And it is even more important in patients with left ventricular dysfunction, defined as a left ventricular ejection fraction less than 50%. In this subgroup of patients, it seems to alter even more their survival if they do have a PPM. So this is some studies, literature reviews showing that some studies failed to demonstrate an poor impact on survival. However, you have to pay into attention that the definition to identify and to quantify mismatch is not necessarily the same between all the teams. Basically, it also alters negatively the durability of bioprosthesis. Patients with PPM have a lower durability than patients without PPM, and also functional capacities. This is a series of patients with PPM and coronary artery disease, and they have shown that patients with no PPM were able to achieve 65% of predicted exercise capacity versus only 57 patients if they do have PPM. So how to prevent, how to predict? So in this statement written on the slide, valve size refers to the indexed effective orifice area rather than the labeled valve size. And important in this statement is that you have to use a three-step protocol elaborated by Philippe Pibarot and Duménil. First, you have to calculate the body surface area. Then you have to calculate the effective orifice area required to get an indexed effective orifice area greater than 0.85% centimeter square per meter square to ensure a minimal indexed effective orifice area for a given patient. And then you have to select the type and the size greater or equal to the effective orifice area determined in step number 2. The gold standard of the evaluation of prosthesis is echocardiography at rest, but as Professor Henke told you, it doesn't reflect the hemodynamic changes during daily activity, which correspond to mild to moderate exercise, with increase or decrease in transvalvular pressure gradient and increase and decrease in effective orifice area. So we decided to evaluate such patients by exercise echocardiography. One important point in our study, we included patients who have been implanted by trifecta, is that the external pericardial sheath allows a bigger area surface for blood flow in comparison to other prostheses where the pericardial sheath is mounted inside the stent, which has an importance for our study. This is a three-dimensional transesophageal echocardiographic aspect of this trifecta aortic valve. And the first paper was made by this group comparing two bioprostheses from the same manufacturer, EPIC valve and trifecta valve, same mode of implantation, supraannular, same measurements, same sizes, and they have shown a significant reduction in severe PPM in patients with trifecta in comparison to patients with EPIC valve, confirming that it was something due to the intrinsic characteristics of the trifecta valve. In our study, we wanted to evaluate the hemodynamic performance during exercise based on the fact that there were excellent reports at rest and there were few data available on the hemodynamic profile during exercise. So between February 2011 and November 2012, 85 patients with severe symptomatic aortic stenosis got aortic valve replacement with the trifecta in 3 centers in France, Amiens, Rennes, and Angers, and all of them who were able to perform an exercise underwent a quantitative Doppler echocardiography at rest, low level, and peak exercise. And here is an example of a patient. Its data were manually stored and for offline analysis. And these are an example of measurements from rest to peak exercise in a representative patient. So the mean size of the prosthesis was 22 millimeters, with most patients implanted with 21 and 23 millimeters. These are the hemodynamic results at rest and at exercise in the overall population and according to the prosthesis size. So what is important was that at rest, all the patients had transvalvular gradient less than 20 millimeters of mercury, and more than half of them had less than 10 millimeters of mercury. And at exercise, only 15 patients had transvalvular gradient greater than 20 millimeters of mercury. Now, non-valvular echocardiographic data, you have here ejection fraction, diastolic function, systolic artery pressure. I won't go through. This is the evolution of mean transprosthetic gradient from rest to peak exercise in the whole population. And this is the evolution of the mean transprosthetic gradient from rest to exercise according to the prosthetic valvular size. Inter and intra-observer variability was very good at rest. It increases a little bit at exercise, but still remain low and acceptable. Now, regarding PPM. So, PPM was present in 23% of patients in our population. Mostly was moderate mismatch. No patients with the 19 millimeters valve got severe mismatch. And what is it? Also important is that patients with severe or moderate mismatch had a lower effective orifice area both at rest and exercise. And what we have also mentioned in our study is that 22% of patients had low flow state, which is defined as a stroke volume index less than 35 millimeters per meter square at rest, and the effective orifice area was lower in this subgroup of patients. More than a half of patients with PPM had this stroke volume index less than 35 milliliters per meter square. And the prevalence of patients with PPM decreased from 21% at rest to 10% at peak exercise. As well as the indexed effective orifice area increased from rest to exercise by 4% in the overall population and even more, 8% in patients in PPM. So finally, there was an incomplete opening of this valve at rest because of the status of low flow at rest, emphasizing the flow dependency of effective orifice area. And bioprosthesis leaflets are more rigid than those of the native valve, and the extent of their opening is probably more sensitive to variation in flow. And what happened at exercise? Well, flow is increasing, and there is a reserve of opening in this valve, and the increase of flow increases and opens widely, largely the valve area. The other explanation as well is due to the high-strength titanium stent with a great flexibility, allowing thus an adaptation to this low flow and high flow status. And the last study to conclude focused on the small supraannular trifecta diameters. Patients were evaluated only at rest, but at discharge and at 1 year. And you have here the evolution of the gradient, transvalvular pressure gradient from discharge to 1 year. So what I would say to conclude from these two important papers is that the hemodynamic profile of the trifecta is excellent both at rest and exercise, and it's even better in patients with a PPM with kind of a low flow status and in patients with small annulus valvular diameters. Thank you very much for your attention.